video, we're going to talk a little bit about how systemic arterial blood pressure is measured. And really, we should say more so that it's estimated than measured, because this is a very indirect measure of arterial blood pressure. So, first things first, we should probably understand why it's so important to measure the pressure in these systemic arteries that we have shown here in the arm or in the leg. And the rationale really is that there is a clinical reason to do so, in that hypertension, typically hypertension, or more commonly I should say, is linked to significant disease outcomes. And that often involves damage to tissues. Long-term hypertension results in damage to tissues, largely through a process called microvascular rarefaction. And you don't need to know that terminology specifically, the microvascular rarefaction, but what it means is that high blood pressure damages small vessels and tends to, over time, reduce their numbers. And what this means is two things. One is that reduced numbers of the microvessels reduces perfusion to tissues. And so over time, you can end up with what's called peripheral vascular disease, wherein the distal tissues in that systemic arterial tree become oxygen deficient. And it can result in the cells actually dying over time. And of course, that's obviously very bad. Now, the other bad side or bad component of hypertension is that as these small vessels disappear, the resistance goes up, which actually makes pressure go up even more. And so it becomes a vicious cycle of vascular damage, increasing resistance, which increases blood pressure, which damages the vessels more, which increases resistance more, right? And you get the idea, is that it becomes a disease process that requires intervention to avoid quite deleterious side effects. Of course, hypotension, low blood pressure, let me put those terms up here at the top, is also a possibility. So hyper, meaning high blood pressure, right? That's the one that can lead to vessel damage and increased incidence of hypertension. And then there's hypotension, which is when the pressure within these vessels is too low. And if it's too low, it doesn't drive flow properly, and you end up with somewhat similar, not damage to the vessels per se because of high pressure, because it's low pressure, obviously, but reduced blood flow, right? And again, that was a downside of the lost vessels with that microvascular rarefaction. So hypotension without the vessel damage can lead to tissue hypoxia and tissue death if it's really severe. So again, we're measuring this blood pressure clinically to sort of determine whether we are hyper or hypotensive, and then to try to resolve those issues. Now, if we go back to Poiseuille's law from our cardiovascular section, right, that was typically stated as Q equals delta P over R, but if we wrote it more generically for the whole system, it was written as cardiac output flow equals the driving pressure, blood pressure, divided by the resistance to that flow, which is, you can use R, or we usually, for the whole circuit, we say TPR, or total peripheral resistance, meaning resistance of all of the circuit, not just a single vessel or group of vessels. And now you'll notice blood pressure is in this equation, right? And so we can sort of rearrange that equation to solve for blood pressure, right? And of course, if we isolate the blood pressure variable here, we end up with an equation that states that cardiac output times total peripheral resistance equals our blood pressure, right? And so what that means, essentially, is that if cardiac output goes up, blood pressure will go up, right? The more blood you push into the arterial circuit over time, the more pressure there will be in those vessels. That makes sense. If there's more volume in them at a given moment, the pressure on their walls is greater. And the total peripheral resistance is also directly proportional to blood pressure. And this is, we can think of this as sort of regulating the outflow of those arteries. Way down here at the distal, if we follow these vessels all the way out to those little tiny arterioles, right? If we adjust the resistance out there by let's go with constriction, then more blood would be trapped upstream here over time and increase the pressure. So if resistance goes up, pressure would go up because, again, more blood is sort of trapped in that arterial portion of the circuit. It's moving through it, but it's holding a larger volume of blood, stretching those walls to a greater degree, generating a higher pressure when either the input is greater or the outflow is less. Right? Again, outflow goes down if the resistance goes up due to vessel constriction. And that's a lot of that in our cardiovascular control section. Okay, but so what do we really want to say about the blood pressure measurement? Well, we want to point out that the blood pressure that we measure is not constant over time. Now, you're going to see a trace of this in a minute, but it is rhythmically pulsatile. Right? And it's rhythmically pulsatile in the large arteries of the arm or leg or torso, because the heart is an intermittent pump. In other words, it squeezes blood, cardiac output rises dramatically during systole of the heart, which of course would increase blood pressure during systole. And so our peak pressure is our systolic pressure, right? The pressure right there at the spike of our blood pressure, when the heart is ejecting extra volume into that space. And the low pressure here, the trough pressure, is called the diastolic pressure. Well, that's when the heart is no longer ejecting blood. It's in its cycle of filling, but because it's not, so in other words, at that instant, cardiac output is zero, right? If you think about your heartbeat, cardiac output is high and then it's zero, and then it's high and then it's zero, right? Because it has to fill in between those ejections. And so cardiac output high generates the systolic pressure. Cardiac output low, essentially zero, creates your diastolic pressure. Now this pressure, it doesn't go to zero, but it doesn't go to zero because of the elastic recoil of the arteries, and we have a valve back here in the, where we're leaving the heart that closes, right? So the blood doesn't flow backwards into the heart. There's still blood in those vessels, and it's still being compressed by the elastic walls of the arteries, and still the pressure falls, but it only falls to a lower value, not to zero. Now finally, the difference between these two pressures is known as the pulse pressure. Right? So pulse pressure equals the systolic blood pressure minus the diastolic pressure, right? The pulse pressure, the difference between the high pressure during the ejection phase and the low pressure in the non-ejection phase, right? High pressure, low pressure. The difference is our pulse pressure difference, or also known as the pulse pressure. Okay? Now, oftentimes people don't want to, and clinically you'll get your blood pressure, you may know your own blood pressure is 126 over 82 or something like that, right? And that's your systolic pressure over your diastolic pressure. The normal is often written as 120 over 80. And again, this will be in both units, or both terms in millimeters of mercury. But we may also want to talk about sort of a mean pressure, right? What's just the average pressure over time? And the mean arterial pressure equals, now you might think, well, just add the two together and divide by 2, right? And you end up in the middle, right? Well, the problem is that the mean arterial pressure over time is not in the middle. I'll explain in a second here. So it's going to equal the diastolic pressure plus 1/3 of the pulse pressure, right? If it were in the middle, it would be plus 1/2 of the pulse pressure. But so the mean is actually sort of like, down here, a little bit closer to the diastolic pressure. And the rationale for that, and I didn't draw it real well here, but the rationale for that is that over time, we spend more time in diastole, we spend more time down here at lower pressures than we do at these sort of peak high pressures. And so the mean over time is a little bit lower. It's a little closer to the diastolic than it is to the systolic. And so they just sort of average it and say, all right, it's about 1/3 of the way up above diastolic pressure, not fully directly in between, halfway in between. Okay, and that's how you calculate mean arterial pressure once you know the systolic and diastolic pressures. Okay, all right, so now we know why we might want to measure our clinical blood pressure. Now we need to know how we do it. How do we get these systolic and diastolic pressures? Well, one way to do it would be to stick a cannula, literally a tube, right? Stick a needle, right? You'd have a tube, right? And at the end of that tube, you put a needle and you stab it right into the artery. And at the end of this fluid-filled tube, you could have a pressure transducer, right? That would tell us the exact pressure, an electronic device that would tell us the physical pressure of that fluid. All right, well, the problem with that is you have to poke a hole in an artery to do it. And if you've ever seen arterial bleeding, maybe you've only seen it in movies, and movies don't really exaggerate it that much. Because of the high pressure in the arteries relative to the veins, the bleeding tends to be pulsatile. It tends to spurt. And so we don't want to measure our blood pressure that way, just for a clinical measurement. It's very dangerous, obviously potentially messy, and it takes a little longer for that to clot up at that injury site and for it not to potentially start to bleed again. So we really don't want to do that. Okay, so what are we going to do? We're going to use this indirect method using a tool called a sphygmomanometer. Right, the sphygmomanometer is the blood pressure cuff, right? And then we're going to add to that the use of a stethoscope, right? And so the stethoscope is going to allow us to what's called auscultate. Or auscultation is the act of listening. I think I spelled that wrong. Auscultation. Got my L here. So auscultation is the act of listening, right? And that's what a stethoscope allows us to do. We'll come back to what we're listening to, right? And by the way, where we put the stethoscope, we want to put it, notice it's placed on the artery here, right? Or as close to it. Well, you can't see the arteries from the skin surface, so we have to feel for them. And that feeling for the pulse is called palpation. Palpation. Not palpitation, palpation. Right, so we're going to palpate the pulse to know where we put our stethoscope to do the auscultation, the listening. All right, so now let's show you the trace we would actually acquire when we use the stethoscope, and actually when we use an electronic version of a stethoscope. Here we have, this is the blood pressure trace, right? This trace in red here, I'm not going to trace the whole thing. That's our blood pressure trace I just drew a minute ago, going up and down. And here's our cuff pressure, right? Now, if you think about that previous picture, the cuff went around the limb. And if we pump the cuff pressure up, right? Pump it up, pump it up, pump it up. Eventually the cuff pressure will exceed the pressure of the blood vessels within the limb, and it will compress them. If it compresses them completely, there's no blood flow in that arm. There's no blood flow going out to the fingers. There's no blood flow coming back, right? And that's really the reason why getting your blood pressure taken is a little bit uncomfortable, right? It creates this, strong degree of compression. It literally blocks blood flow for a short period to that extremity, usually to your hand, right? And so here's our systolic pressure, right? Now remember, we can't see this trace unless we were to actually use the method with the cannula and poke a hole in the artery, which we don't want to do, right? Here's our diastolic pressure down here, okay? And it's being pulsatile, right? Because it's a large artery. And what we're going to do is we're going to pump the cuff pressure up above your systolic pressure. And again, so at that point, there is no flow, right? There's no flow occurring through the artery. The heart's, right, above the cuff, the pressure's doing this. It's spiking and falling and spiking and falling, right? But no blood is getting past that cuff because the vessel's compressed right there. We're going to drop the pressure in the cuff slowly, right? See this coming down slowly. We're letting the air out of that cuff. And it's going to fall it's going to continue to fall, but it's going to fall initially right below the systolic pressure, right here. Right? See this little blue spot? Right? That's where our systolic pressure is higher than the cuff pressure. Right? Which means the pressure inside the artery is greater than the pressure outside of the artery for a split second. And you get a little bit of flow. Right? Look at this right here. See how it goes no flow, and this is flow right here. That little span of time. Flow. But then watch, your blood pressure falls rapidly. It falls faster than the cuff pressure. So it falls below the cuff pressure. No flow again. Right? And then it rises above it again. Flow. And then below, no flow. Then above, flow. Right? So you see this. We're getting these sort of instances of flow in between periods of no flow. Well, the blood's sort of like spurting through in between here. And as it spurts through, it generates turbulent flow. Turbulent flow is noisy. Here's where a stethoscope comes in. So because it's noisy, the stethoscope will hear it, and the sounds you hear, which is due to turbulent flow in the artery, are called Korotkoff sounds. Right? And so this is a Korotkoff sound, and then there's none because there's no flow, and then there's a Korotkoff sound, then none, right? Then Korotkoff, right? Eventually, you're going to drop your pressure until it's below the diastolic pressure, in which case, right, now it's all flow, right? Look at our blood pressure. It's above the cuff pressure, and it's laminar. No sound, right? If you put a stethoscope on your brachial artery without a cuff on it, you hear nothing. You hear nothing because you have normal laminar flow, which makes no sound. Yes, it's pulsatile, but it's laminar. Only turbulent flow makes noise, these Korotkoff sounds. So we're going to use the Korotkoff sounds as indicators of this turbulent flow, and as indicators, notice at the first Korotkoff sound, the cuff pressure and the blood pressure are really close together, right? The blood pressure's here, the cuff pressure's right there too, and so you can use the cuff pressure as an estimate of blood pressure. We're not literally measuring the blood pressure, but because they're close together, right, when this first sound occurs, we can use that as an estimate of our systolic pressure, right? So there's first rule. Korotkoff sound, first Korotkoff sound indicates your systolic pressure. Keep in mind, these sounds are due to turbulent flow in the brachial artery. We will talk about heart sounds in a separate video. The heart sounds that you hear with a stethoscope on your heart are separate. Those are different events. Okay? It doesn't matter how many Korotkoff sounds occur in between. It could be 6, it could be 28. When you hear the last one, that's when the cuff pressure and the cuff pressure and the issue circle this area right here. When the cuff pressure and the diastolic pressure are close together, right? They're not exact, right? But they're pretty close together. And so we can use the cuff pressure as an estimate of your diastolic pressure when the last Korotkoff sound is heard. Here it is, right? So you want to use the first and the last to estimate your systolic pressure, cuff pressure at the first carotid cough sound, and your diastolic pressure, the cuff pressure at your last carotid cough sound. Okay, and that is how we measure blood pressure, systemic arterial blood pressure, using a sphygmomanometer and stethoscope to auscultate for the carotid cough sounds, the turbulent flow in a partially occluded brachial artery. And again, or any other artery that you want to compress and occlude with the sphygmomanometer.